Society's annual reception, a reception that we have brought to the virtual stage for the very first time. 2020 has been a year unlike any we have ever experienced, and we had to follow suit with our reception. I'm going to just give you a brief explanation of what the Legacy Society is, and then I will introduce the main events for the evening. The John T. Mather Legacy Society was established to honor our founder and recognize the generosity of those who have included Mather Hospital in their estate plans or who have made a planned gift. On December 29th, 1929, Mather Hospital opened its doors for the first time as the result of a significant gift in the will of Mr. Mather. Mr. Mather's vision was to build the first hospital in the town of Brookhaven that would provide quality, compassionate healthcare to everyone in that community, a community he called home. And for almost a century, Mather Hospital has stood as a testament to one man's foresight and thoughtfulness. Mr. Mather's gift truly is our community's treasure. Now, we do have one distinction that I will mention, and then I'll get off this, but Mather Hospital has the distinct honor of being the only Northwell affiliated hospital that exists because of a bequest. So our community is united by the legacy of John T. Mather, and we have helped transform his dream into a reality. And it is now up to us to ensure that his legacy continues for generations to come. So on to why everybody is here. Our first guest speaker this evening is one of Mather's infectious disease specialists, Dr. Philip Nizza. Dr. Nizza received his undergraduate degree from NYU, and he attended medical school at the New York College of Osteopathic Medicine. In honor of his late wife, Natalie, Dr. Nizza has established a scholarship at NICOM for a female graduate who will be going into primary care. This is the scholarship's inaugural year, and Dr. Nizza and his two sons, Rudolph and Joseph, will be selecting the recipient. So please welcome Dr. Nizza to explain what's been going on with COVID and how we are going to manage going forward. Dr. Nizza.
This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Okay, good evening. I'd like to thank everyone for having me. I am Dr. Nizza. I'm the Chief of Infectious Disease at Mather Hospital, and have been on staff here since 2002. With that kind of lead in, I hope no one is expecting, I don't expect I'll be damaging anybody or causing any serious harm, but want to give a general audience an idea of what COVID has done and what is done to Mather Hospital, where I spent almost multiple days during the pandemic since its inception. So I've been on Long Island my whole life. So the only good thing you could say about the pandemic is the roads opened up nicely and you can actually travel back and forth. Something that hasn't happened, I think, since I've been born here. As mentioned, I did my medical residency at North Shore University Hospital in Manhasset for internal medicine before it was Northwell, before everyone looked north. It was an excellent university hospital, and that's where I did my internal medicine training, and then followed that up with infectious disease training at Memorial Sloan Kettering Cancer Center. I have been lucky enough and blessed by my peers to have been nominated and received a Theodore Roosevelt Award in 2017, and am the longest standing physician champion as of 2019, only because the pandemic hasn't allowed us to give the award out for 2020. So I will have the longest running tenure of the champion. So just a funny aside of that my colleagues like to rib me for every day. I live in Setauket, as mentioned. I have 2 teenage sons. The only thing harder than COVID is raising 2 teenage sons. So it's we think the pandemic is challenging. I think this gives it a run for its money.
Dr. Nizza, I just wanted to mention one more thing. I apologize. Everyone, if you have questions going forward, you can actually type them into the Q&A button at the bottom of your screen, and you can enter those as the presentation is being done. You don't have to wait until the end. And if for some reason we don't get to your questions, we will be following up with an email with the responses. Thank you, Dr. Nizza. Sorry about that.
No problem. So what's always made Mather important to me is its family atmosphere and the character of its employees. I can remember my first day as if it was yesterday. I remember being greeted by Alice, if anyone works in the hospital, who is the most wonderful, sweet woman who's our unit secretary on 2 East. And from the minute I got there, she did not know who I was. I was like a deer in the headlights when I walked up the elevator on July 2nd, 2002. Woman came in, what can I help you with? What can I help you find? What can I do to make your day here better? And that has been a theme amongst every employee in that hospital and every discipline of that hospital. They take pride in their job. And it's a place that I would feel comfortable sending my family, and I have, just based on that family atmosphere. And I think as the hospital has continued to grow from a community hospital with a voluntary medical staff to a facility with now multiple residency programs and an affiliation in the Northwell Health System, I think it's the family-like atmosphere that will continue to set us apart from even other hospitals in the Northwell network. So this is a picture of me and my partner, Dr. Galinkin, and the caption on social media for this picture was 2 infectious disease doctors with hands-on corona experience. So if you can see what we're holding in our hands, you might get the joke. So we were happily and enjoying an Islander game on February 29th as diehard hockey fans and having the time of our lives. We had been and actually met the owner of the Islanders that night. We were lucky enough to have met Mr. Ledecky, and he treated myself and our children very well. And then things started to change once March rolled around. Then this hit, the new enemy. So infectious disease guys or science nerds like me always like a good electron micrograph of an organism. And this is what coronavirus it is. It almost looks like a Christmas ornament. Nice, bright red, little extensions and a well soft gray ball. And this is what it looks like up close. And those little things sticking out of the center of that ball are the spike proteins, which are responsible for how the virus adheres, gets into your airways and causes the disease that it does. Excuse me. And this is my outfit in maybe March, or this picture is dated December 15th, but pretty much from the end of February all the way through, this is my day-to-day dressings. A lot different than a hockey jersey. Full face shield, an N95 respirator covered by a regular surgical mask, a head-to-toe suit and gown, gloves, and try walking into about 20 to 25 patient rooms, taking these gowns on and off, communicating, trying to speak to patients, give them information, try to treat them and assure them that they were going to get better, all through a windshield, basically a car windshield, wearing a muffler over your face. So this is what myself and every doctor and nurse, aide, and who went in the rooms were dressed like during the right in the heart of the first wave and going forward now in the second wave. So this is the COVID-19 pandemic, as we know, started at the very end of 2019. So it was a novel coronavirus, and its very fancy long $10 medical name is Severe Acute Respiratory Syndrome Coronavirus 2, or SARS-CoV-2. And then because it was diagnosed in 2019, it has been shortened to the much more acceptable COVID-19, or as in slang people putting all over the internet, the vid, which is not acceptable. But we are in the middle of COVID-19. This is the virus that is responsible for this outbreak, and it has an extreme worldwide impact. 1.9 million deaths, over now 300,000 deaths in the United States. And I cannot say this enough to anyone who has thought it or has a relative who thinks it and has been in this since the beginning of March. This is no hoax. Quite real, quite deadly, and facing it every day to day really, unless you're in it every day, I think I cannot put into words what we see and what we're experiencing. As someone who's been a doctor since graduating medical school in 1997, so in 23 years, I can't recall anything I've ever seen like this. So a little background, coronaviruses have been around for a very long time. They are not new, okay? So coronaviruses comprise a vast family of 7 types that can cause disease in humans. Some coronaviruses can affect animals and then can evolve to affect humans, which is kind of what we think happened in this outbreak, postulated to have originated in a large animal, or what they call wet market, seafood market, with the mixing of fluids between animals and humans, and possibly the initial start point for this infection, okay? If those of you who were watching the news as far back as 2003 would remember something called Sars, which was a severe adult respiratory syndrome, which was a pulmonary virus in 2003, and MERS, which is Mideastern Respiratory Syndrome, in 2012. They too are coronaviruses in the same family as COVID. But the outbreaks in these cases, they were fairly aggressive and fatal, but unlike COVID, these outbreaks were self-limited and did not have the global impact that this virus has. So this is a busy slide, and I'm not going to go everything, and this only goes from the end of December, almost a year ago, to April of this year. So December 31st, the cases start to appear in Wuhan. The first death is reported January 11th, okay? End of January, we're in a public health emergency according to the World Health Organization. And then on March 11th, we are officially declared a pandemic. And by March 26th, the United States, unfortunately, has reported to lead the world in the number of confirmed cases. And then on the 13th of March, the president did declare a national emergency. And by April, we were recommended wearing a protective cloth face mask and in public settings. So it has really evolved to where you see it now. The speed at which this has evolved and the rapidly changing data, I think, has been unseen in infectious disease history like this. But because of the common connectivity of the world between the internet and the TV and the constant bombardment of media, the information and the facts have come to light quick and rapidly, and you have to determine sometimes what's true and what's not. So it's been quite an amazing change from December 31st, even just till now. So early on at Mather, right on the front line, seeing these cases in the beginning, I can tell you there was a lot of fear amongst myself as well. I don't claim to be entirely brave. I remember the day I walked in my first patient's room who was diagnosed, who had to go on a ventilator because he was unable to breathe. And walking in there with that gown and mask and shield on for the very first time, I must say, I myself was a little anxious and sweaty. But at the end of the day, myself and everyone, again, I can't praise the nursing staff enough or the other doctors in terms of they knew what their job was to do, why we all went into this field, no matter what your discipline, was to help others. And you walked in and they were motivated and they did their job. The fear was replaced by motivation to become stronger. We were using drugs that were not designed as antivirals to treat these patients. We had little clinical data. The infection rates were rising and things were changing fast and furious. And not being able to have all the answers as a physician, I could tell you, is one of the more frustrating aspects of this case, especially in the beginning. We didn't know necessarily where we were going, and trying to keep on top of the ever-changing media stream of what was happening was quite frightening at the time. And as I said, I cannot be prouder of the entire Mather Hospital staff. They pulled together during uncertain times like I'd not seen, and continue to do so now as Wave 2 is going on. They saved as many lives as they could with the resources we had available. And I think the whole staff of the hospital deserves an amazing amount of praise and regard for what they were able to do. So the teamwork aspect from the hospital end went down from administration straight through security, medicine, sanitation staff, food vendors, everything. Everyone was working as a team. We had daily meetings to assess our situation. And I must say they did everything they could to make sure we had the PPE or protective equipment and resources we need to care for our patients. Physicians were constantly on their phone. Oh, I heard this, I read this data is coming out of here, I have a friend here. Everyone just trying to do anything we can to find a spark or something that would improve our patients' outcomes. You had never seen a hospital like this. Patients were on ventilators spread throughout the hospital, not just in the intensive care unit. There are over 35 people at one point on ventilators spread throughout the hospital. And the patients were scared. They couldn't breathe. Many were gasping for air. Many weren't, then almost all were unable to see their families. And the nursing staff and even the physicians and everyone else became their families. We not only had to provide medical treatment, but we had to help ease their anxiety, speak to their families, and go as an intermediary for people who were without the most important thing, their loved ones around them. So this is a typical Mather clap out event, which every time a patient was discharged from the hospital during the heat of the pandemic, we played Don't Stop Believing, was blasted through the loudspeakers for at least a few seconds as the patients were wheeled out. And many of the staff who took care of them and the hospital staff gathered outside to applaud them as they were taken from an ambulance to home or to rehabilitation or to their next destination. I have a personal story in that I took care of an employee who I saw day one, who was in the hospital for over 70 days. And during that course of that patient's illness, that employee's illness, the ups and downs were unbelievable. Patient almost unfortunately died on multiple occasions and came fighting back each time. And when the family was there to greet them at the end of the day, I actually made sure I went down there to watch that. And I got to say, it was one of the best, most rewarding moments of my life as a physician. Next. So what have we learned in our time from COVID? In the beginning, we were very afraid of steroids, and we were very afraid of anti-inflammatories like Motrin and Motrin for fevers, because we didn't want to suppress the immune system. We're going to make the infection worse. And now, unfortunately, steroids are okay and the standard of care, and have become very helpful in taking down the inflammation in the lungs that these people are experiencing. We also learned not to ventilate people and not attach people to ventilators early if you can help it. Try every means necessary, and now only try to use a respirator as a last resort. Something as simple as putting a patient on their stomach when they were sleeping or resting showed dramatic results on the basis of where air flows in the lung. Their saturations in their end would go from 85% on a 100% face mask up to 93, 94% just by getting them on their stomach. And Mather itself had its own, what they call proning team, where they would come in the ICU every day and round and get ventilated patients with multiple tubes and wires as a group, walk in there and put them on their stomachs to improve their ability to oxygenate and get oxygen to their vital organs. It was an amazing thing to see. And like I said, the teamwork with which they did this astounded me. We also learned that these patients are very high risk of blood clots. We saw people get blood clots in their legs and their lungs, and now using blood thinners early on or upfront in disease is much more common than it was during the first wave. So in the treatment area, in the beginning, we had many untried, unproven combinations, and we were desperate. So, Plaquenil caused quite a stir in the beginning of the outbreak with Zithromax. Pepcid, which is a drug used for heartburn, believe it or not, was even trialed to decrease inflammation and used in this infection. And doxycycline, these are old antibiotics and anti-inflammatories, but none of them are antivirals. They don't have any specific viral interactions, and these were off-label uses. We had subsequent randomized trial data after this happened that showed actually no clinical benefit from these medications. And in the very first wave, I must say, we felt very helpless to some point. Data was evolving rapidly, and based on case stories or anecdotal reports, it was very hard to tell what therapy was effective and what therapy was not. So what do we have now? Well, as of end of December 2020, we have Remdesivir. So Remdesivir was a much hyped antiviral drug that came to market initially as an experimental for COVID, but actually initially was invented way back in 2014 for treatment of Ebola virus infections during those outbreaks in Africa. It was determined that it was active against many RNA viruses, including other coronaviruses like MERS and SARS, which were previously mentioned. And it tries to inhibit viral replication. It's an IV form only, so there's no pill for it. If you're getting this drug, you will be hospitalized. And it's best given early on in the illness as opposed to late. At least we've seen the best outcomes when given early. When patients just turning a bad corner, needing oxygen, initiation of this drug is when that drug should be started, and has shown the best patient improvement, at least in my clinical experience. Okay, and it cannot be used in any patient who has a severe kidney or liver injury. Steroids, as mentioned, I think this is the one game changer in the second wave that we didn't have during the first wave. So we use Decadron as the steroid of choice. It is very potent, okay, much more potent per milligram strength than prednisone and solumedrol. And it is now initiated early in the disease, usually for a 10-day course or until they leave the hospital. That is the current standard of care and recommendation. It can be given both by an IV and a pill form, which is nice. So if the patients are improving and need to finish therapy, they can be transitioned to an oral form of the medication. What we believe happens a lot in this disease is something called Cytokine Storm, where your body's anti-inflammatory proteins go into almost a cyclone, and that cyclone causes extensive lung damage. And some of this steroid treatment is to hope to calm that lung damage down before it gets to the point of no return. And it's been shown that when given to patients with this infection, it reduced their mortality compared to 28 days compared to the others who had not received it. And because the short-term use of 10 days, there's very few side effects. It can elevate your blood glucose, it can elevate your white cell count, your blood work. But in terms of long-term side effects, likely very few because the course of therapy is so short. So treatment, monoclonal antibodies are all the rage right now. Patients have walked in by name and say, I need that cocktail the president got. So I'll say the gin and tonic, which one would you like? But the cocktail is monoclonal antibodies, which is a little different than convalescent serum. So convalescent serum was what we were doing during the first wave, where we were pooling blood specimens, or actually plasma specimens of patients who were infected, and trying to infuse that plasma into infected patients to see if any antibodies in that plasma would help bind the virus and affect their patient's outcome. Personally, I had not seen much improvement with use of convalescent serum, and the data has been, moderate to mild at best in terms of improvement. So two companies right now, Regeneron and Eli Lilly, decided to streamline the process, and they basically are monoclonal, one line of antibodies that target the spike protein, which the virus uses to enter our cells. It's a very tricky drug, and there's more data coming out as we know. Currently, the guidelines are for one-time infusion, usually given in an outpatient or an ER setting, designed for patients who have risk factors for severe infection. And what are those risk factors, and what have we seen since the outbreak has started? Anyone with chronic lung disease, morbid obesity is a very large risk factor, believe it or not, and one of the biggest I've seen in terms of having a poor outcome, and diabetes. So if you have one or two risk factors, you're not on oxygen yet, but you look like you're going to have a bad outcome, giving this early may stave off from going from mild infection to severe infection. And because it is a monoclonal antibody, there is a risk of an allergic reaction, and patients must be observed after the infusion is given for that. So new antivirals are also on the horizon. I won't go over all of them. The most interesting one that has been popped up in the ID world is a drug called molnupiravir, which is an oral antiviral medication that may be even more potent than remdesivir, and has activity not only against COVID, but possibly other respiratory viruses, including influenza. What's different about the drug is not only its potency, but possibly the fact that it comes in a pill form, which could be a game changer in terms of treating people both on an inpatient and outpatient setting, where right now the only antiviral medication we have must be given intravenously. And hopefully there is much more to follow as research and development chugs along and tries to catch up. One thing we have shown as a nation to be resourceful in coming up with new therapies. So vaccines, again, obviously very prominent in the Northwell system and in the news. Those of us watching any news feed are seeing patients getting first doses of vaccine. I myself am scheduled to get my vaccine on Thursday afternoon, and I'm looking forward to it, and I can't wait. I'm a firm believer in the science behind things, and trying to protect myself and my family and my patients. So the vaccines that we currently have out there have two mechanisms of action. You've heard of Moderna and Pfizer. These are the vaccines that are being authorized for emergency use, and they work via this new technology called messenger RNA technology, or mRNA. This technology has been around actually since I think 2014. It's just now that they found a way to stabilize it for use. And so previously, the whole history of vaccines was that you put a weakened, inactivated germ, bacteria, or virus into our body to stimulate the immune system. As a matter of fact, as a little historical note, people know vaccines, the word vaca is vaccine for cow, and it goes back to Dr. Jenner in discovering smallpox vaccine by noticing that milkmaids who were taking care of cows did not get smallpox, but because they were exposed to cowpox. And by grinding up those vesicles and injecting himself, he essentially invented the first vaccine. And mRNA vaccines are brand new technologies. So what they do is they teach our own cells to make a protein, just the one piece, the spike protein in this case, which causes our own body to make an immune response to this protein when it's made, just stop us from getting infected if we're exposed to the real virus. So the vaccine gets injected into the muscle. It causes our own muscle cells to assemble a piece of protein called a spike protein, and then our immune system will create antibodies, as would happen in natural infection. What's also important to know here is that infectious disease and immunity works by two cells, B cells, which make antibodies, and T cells, which are the memory cells that are responsible for long-lasting immunity. Initial data coming out is that these vaccines have a fairly good T cell response, which means the memory for this disease can last hopefully a fairly long time. And a couple of myths to clear up. You cannot get the disease from the vaccination, period. And there is no way it alters your genetics. You're not going to become a superhero or the Hulk by incorporating viral, half virus, half human. That is not the way it works. And I know there's a lot of information and I answered questions on while rounding at the hospital this weekend. Both vaccines must be kept in extremely cold storage, minus 80 degrees for the Pfizer vaccine, and I think negative 8 degrees for the Mrna vaccine. The other route being explored for vaccination and immunity is by Johnson & Johnson and AstraZeneca, who are using modified adenovirus. Adenovirus is a virus that causes the common cold, much like rhinovirus and coronavirus, to present the immune system. Again, these viral proteins attached to this adenovirus kind of as the carrier, or if you thought of it as a football game, your adenovirus is kind of your lead blocker, and it drags with it the viral proteins from the coronavirus to develop immunity. The Johnson & Johnson version is currently possibly even a one-shot regimen, though the Moderna and Pfizer vaccines are 2 shots to be given 3 weeks apart, but it's likely that everything will come down to a 2-shot series in the future. Side effects are usually, with any vaccine, localized arm soreness, low-grade fever, and even mild COVID-like 19 symptoms. As mentioned, high-risk people, EMS staff, nursing home patients, frontline physicians are being vaccinated. I wrote here at the end of the month about being vaccinated right now. And like I said, I'm anxious to receive mine by the end of the week. Questions that often come up: it is not clear whether yearly vaccine will be required. This is unknown. This will have to be sorted out over the coming year. Experts feel we'll need a 70% vaccination rate to attain that magical herd immunity, where so many are protected that it would slow the spread and put an end to the pandemic. Vaccination may reduce infection. We know that. Actually, it's 95% effective in preventing infection, but it's unclear if it stops someone from becoming a carrier and therefore transmitting it. And therefore, mask wearing and distancing will likely be needed at least well into the summer. And there's still much fear. I've not, as a physician who's been an infectious disease doctor for 20 years, quite understand why vaccination is more so than any field of medicine or therapeutics engenders much more fear than anything else. And I think we have to be calm, be people of science and knowledge, and pass this education and reassurance along to those who need it, especially those who are high risk. So I'd like to thank everyone for their attention. I hope everyone continues to stay safe and practice social distancing during these hard times, especially during the holiday season. And believe me, having a big Italian family, I know this is rough. Separating, I might have to cut down the 7 fishes to 3 fishes this year, just because the party's going to be a lot smaller. And may you and your family have a very happy holiday season. So I'll take any questions, I guess, at this point. As many, squeeze in as many as I can. So question one that's popped up. I am 60, I have asthma, I have severe allergies, food, inhalants, meds, and very concerned about getting a vaccine. Where does that leave me? Where it leaves you is having to play with everything we do in this world is risk benefit. The asthma alone is enough of a risk factor where if you have underlying lung disease and get this virus, the outcome could be worse. So I would favor getting a vaccine, and you'll be in an observed setting. And if something happens, then we'll have to treat any allergic reaction. Next question is, when will people with diabetes likely get the vaccine? It's unclear. That'll probably be the third phase when it's rolled out to the general public. Next wave after us in the nursing homes will probably be people in community settings, possibly teachers or people at first contacts in colleges. It's unclear how the rollout is going to go beyond the first responders at this current moment. Is there anything else? Is my feed frozen? Oh, no.
There's another question. As a young nurse, I'm still looking forward to my family growing and would like to know your thoughts on getting this vaccine and the infertility rumors on the vaccine.
So if you go to Snopes or any of the fact debunking websites, there is no proof to this fertility rumor. This is the one question I did answer many times along my travels this weekend while on call. There's simply no data that proves that fertility is going to be at risk for anyone. Obviously, with a new product, and women of young childbearing age, of course, are going to be concerned. But as of right now, there is no substantiated data that vaccination will harm, either cause sterility or cause future damage to newborn children. The data just isn't maybe it's not there yet, but there's no proof in the trials or anyone else that's had these studies that this is the case.
How do you determine which is for you?
As far as which vaccine, me personally, it's hard to say. I think they're both. We know more about the mRNA vaccines right now. At least I do anyway, and that's what I'm going to receive. So I think the technology has the most hope for both lasting immunity and actually a technology that could be applied to other viruses, including influenza and other things that plague us in the future.
Someone said, thanks for all you do for us.
You're very welcome.
Will your children, if they're over 16, get the vaccine when they can?
100%. 100%. I will take them as soon as it's available.
Have you used the monoclonal antibodies at Mather?
Not at Mather. At another hospital I do attend, I've given it to 3 people. I've not had follow-up with them, but I think they've stayed out of the hospital when they were given. They were high-risk patients with lung disease and morbid obesity. And as far as I know, both have done well and stayed away from the hospital.
Could there eventually be at-home testing kits to avoid uncertainty?
Yeah, the question with anything as an at-home kit is always, what's the reliability? How capable are people of doing it at home? And what is the false positive and false negative rate? I've not seen the data enough to know how accurate these tests are going to be. Which
is the best type, 1 shot or 2?
Oh, all vaccines are going to require 2 shots. So to me, they're going to be 2-shot series, I think, except for 1, and I think they're going to even lean towards that too. So I don't think you can avoid 2 shots. And if you sign up for the series, you can't just take 1. You should follow through and take both doses.
How can one get the virus and still spread it even after being vaccinated? What's the mechanism?
Well, the mechanism is not that the virus won't have an attachment point in the lungs to cause disease, but it may still inhabit cells in the nasopharynx and in the oropharynx. So it may be sitting there, wants to get in, it can't get in because it has antibodies, but you could still spread it through airborne transmission. That is the current thought. So you may be protected from infection, but not protected from transmission.
Okay, and we have a handful of other questions that we're going to have to follow up with, but I'm just going to read one last one.
Great.
And thank you so much, Dr. Nizza. And everybody, please know we will email you with the replies to your remaining questions. We won't forget any. The last question is, I had asthma in my teens and my early 30s. It is controlled by using Allegra if exposed to pets and other environmental allergies. Would I be considered someone with asthma?
I think if you probably if you're having you're still taking medications such as inhalers or at risk of having reactive airway disease, then I don't know. I guess by a pulmonologist definition, you probably don't have severe asthma if you're in and out. But the fact that you have a history of bronchospasm in your past and inflammatory lung disease does put you at increased risk, but not so much as someone would say oxygen-dependent emphysema who's on multiple inhalers at home. Those are much higher risk patients.
Thank you very much, Dr. Nizza. Thank you for joining us.
You're very welcome.
I just wanted to mention in closing that the word legacy has many meanings for me. And in thinking on it, preparing for tonight, there's one word that kept coming to mind, and that's together. Part of what makes Mather feel like a family is one of our themes. Together we can. Together is a very powerful word. When we come together, we create something bigger, a connection, a community, a quiet magic that ripples out in thousands of ways to people and places beyond ourselves. It takes each of us to make a difference for all of us, and together we can.